Today my topic is previous caesarean delivery with VBAC, vaginal birth after the caesarean section. So I'll give the introduction of the caesarean section. Definition. Caesarean section is removal of the fetus from the uterus by abdominal and uterine incisions after 28 weeks of the pregnancy. Pregnant women with previous caesarean section may be offered either planned VBAC, vaginal birth after caesarean section, or elective repeat caesarean section. So options for the patient with previous caesarean section. Elective repeat caesarean delivery, also called ERCS. So trial of labor after caesarean section, that is TOLAC. We can offer the patient for the trial of labor and have a vaginal birth after caesarean section. This can have two outcomes. Successful TOLAC, that is trial of labor after caesarean section, that is vaginal birth after caesarean delivery. So failed TOLAC. So in the failed TOLAC, what will happen? If there is failure in the trial of labor after caesarean section, may need of emergency caesarean delivery. So which women are the best suited to have a planned VBAC? Planned VBAC. VBAC is vaginal birth after caesarean section. Is appropriate for and may be offered to the majority of women with a singleton pregnancy of cephalic presentation at 37 weeks of pregnancy or behind, who have had a single previous lower segment caesarean delivery with or without the history of previous vaginal birth. So risks and benefits of opting for VBAC versus ERCS from 39 weeks of gestation. So maternal outcome in a planned VBAC and ERCS, 70 to 75% chance of successful VBAC. 0.5% risk of uterine scar rupture will be there. Increases likelihood of future vaginal birth, instrumental delivery is up to 39%. Risk of maternal death 4 in 1 lakh. Elective repeated caesarean section is able to plan to know the delivery date in selected patients. Avoid the risk of uterine rupture, longer recovery will be there, reduces the risk of pelvic organ prolapse and urinary problems, option for sterilization if fertility is no longer desired, future pregnancies likely to require caesarean delivery, increased risk of placenta previa, accreta and additions with successive caesarean deliveries, risk of maternal deaths. Infant outcome in a planned VBAC and ERCS. Risk of transient respiratory morbidity of 2 to 3% is there. 0.08% risk hypoxic ischemic encephalopathy is there. 0.04% risk of delivery related perinatal death is there. Risk of transient respiratory morbidity is there of 4 to 5%. Less than 1% in 1000 was less than 0.01% risk of delivery related perinatal death or HIV. Selection of candidates for VBAC. So how do you select for vaginal birth after caesarean section? So one previous prior low transverse caesarean delivery, clinically adequate pelvis should be there, no other uterine scar, previous ruptures, No other uterine scar is like she must have not undergone any myomectomy or previous history of any scar rupture. Physician immediately available throughout active labor, capable of monitoring the labor, performing an emergency cesarean section. Availability of anesthesia and emergency cesarean delivery. Contraindications of TOLAC, trial of labor in after cesarean section. Like previous uterine rupture, previous high vertical classical T-shaped cesarean section, 3 or more previous cesarean deliveries, contracted pelvis, obstetrics or medical complications, malpresentation, APH, severe PIH, eclampsia, placental insufficiency, medical disorders like hypertension, heart disease, asthma, and seizure disorders. Contraindicated to look inability to perform emergency cesarean due to insufficient staffing facilities where the woman herself refuses. These are all the contraindications of TOLAC. Factors influencing success of VBAC. Type of prior uterine incision, prior uterine rupture, closure of prior incision, interdelivery interval, number of prior caesarean incision, prior vaginal delivery. Factors influencing success of VBAC is indication for prior caesarean delivery, fetal size, multiple fetal gestation, maternal obesity. These are the types of prior uterine incision and estimated risk for uterine rupture. Estimated rupture rate is classical caesarean section 4 to 9, T-shaped 4 to 9, low vertical 1 to 7, low transverse is 0.2 to 1.5%. Prior uterine rupture is lower segment is 6 and upper uterus is 32. So closure of prior incisions. So no relation between a 1 and a 2 layer closure and the risk of subsequent uterine rupture. So no increased risk of rupture. They reported that uterine descent was more common after single layer closure. In a single layer closure was associated with nearly a fourfold increase of rupture compared with the double layer closure. Interdelivery interval. So what is this interdelivery interval is? Having at least, there should be a gap of having at least 24 months between the date of the last cesarean birth and due date for this pregnancy, increases the chances of successful VBAC and decreases the risk of the uterine rupture. At least there should be gap next conception, 24 months gap should be there to have a successful VBAC. Intervals of 18 months or less were associated with threefold increased risk of symptomatic rupture during a subsequent trial of labor compared with the intervals greater than 18 months. Number of prior caesarean incisions. Uterine rupture rates of 0.6% following one caesarean delivery and 1.8% for women with prior caesarean deliveries. Two prior caesarean deliveries have 1.8% compared with those with one. Prior vaginal delivery. Previous vaginal birth, particularly previous VBAC, is the single best predictor for successful VBAC. 87% to 90% success rate for a planned VBAC. The rate of rupture increases with each successive labor. But a prior vaginal delivery also increases the chances of successful VBAC attempt. So indications for the prior caesarean delivery. Malpresentation such as breech presentation, success rate is 91%. Fetal distress, the success rate will be 84%. Prior dystocia is an important predictor of vaginal delivery after prior cesarean. Dystocia as the original indication had a significantly lower success rate compared to those with other indications. Fetal size. No proof that increasing fetal size increases the risk of uterine rupture with a VBAC. So compare the outcome of almost 2,750 women undergoing a trial of labor, of whom 1.1% had a uterine rupture. The rate increased with the increasing fetal weight. 1% for less than 4 kgs, 1.6% for more than 4 kgs, and 2.4% for more than 4.25 kgs. Multifetal gestation. So twin pregnancy, no increased risk of uterine rupture with VBAC. Uterine rupture rates of 0.7% to 1.1% and vaginal delivery rates of 75% to 85%. Maternal obesity. Obesity decreases the success of VBAC.